welcome to another video from the CTAD Clinic. My name's Dr. Mike Lloyd and I'm the director of the clinic. Today I want to be talking about issues of diagnosis and categories, classification of diagnosis. This largely comes because a lot of people have been leaving comments or suggestions about ideas or opinions or thoughts about the category of other specified dissociative disorders, whether that's type 1 or type 2. So I thought what would be useful today is to try and have a bit of an understanding or a discussion, I suppose, about what is actually meant by other specified dissociative disorder and whether in fact we've got this right as a diagnostic category. It may well be that what we've actually done is we've miscategorized this as an aspect of dissociation. For that reason I thought it'd be useful at least to offer some thoughts that I've had on this, and as well as drawing on the work of Dell and Nijenhuis and Paul Dell, who have written substantial amounts of information about these diagnostic categories, reviewing the difference between the Diagnostic and Statistical Manual 4 and 5, and also taking on information from the American Psychiatric Association. These are really great authors that have really tried to understand what is meant by the intent of the classification system of dissociation and how it may actually not be doing us any favours when we categorise these things. One of the reasons why that they've been particularly interested in this and how in the West there is a different diagnostic system appearing between Europe and the United States. So the thresholds appear to be different. The threshold for diagnosing dissociative identity disorder, DID, appears higher in Europe. That in order to attain that diagnosis there has to be substantial levels of amnesia present, and the switching between different identities or parts or EPs has to be really quite elaborate. In the US, this seems to be slightly different, so the threshold is lower. What we see then is a higher rate of diagnosis for the other specified dissociative disorder categories, and in the States we see more DID. This is of interest because the system of diagnosing these, which is realistically the Structured Clinical Interview for Dissociative Disorders booklet written by Marlene Steinberg, these are being used by both European and American colleagues when diagnosing. So we shouldn't have these differences. This may then come down to the problematic description of what other specified dissociative disorder actually is. And we draw on the original variant from the DSM-IV of the not otherwise specified dissociative disorder, which a lot of people were diagnosed with quite happily. That was a diagnosis that seemed to be relevant to them. But when the move to other specified came in, it seemed problematic, and a lot of people have talked to me about that they don't like that shift in diagnostic category from one to the other. So I thought it would be useful to sort of dig down into this a little bit and try and make a bit of sense of it. To begin with, the labelling of the other specified effectively means this. Individuals with dissociative disorders that do not meet the full criteria for one of the disorders in the dissociative disorders diagnostic class must be diagnosed as other specified dissociative disorder. The way of then determining what that means is to look at the examples set out by the DSM, and these are that they have to involve chronic and recurrent syndromes of mixed dissociative symptoms, identity disturbance due to prolonged and intensive coercive persuasion, acute dissociative reactions to stressful events, and dissociative trance. What it looks at is the type of dissociation that's actually taking place. According to the theory of structural dissociation, we have ANPs and EPs, apparent normal personalities and emotional personalities. Both DID and OSDD can have ANPs and EPs. What makes the difference is the level of severity or the impact on the individual in terms of the cognitions, the emotions and the behaviour that are presenting. We know that DDNOS shared many features with DID, so there were changes in personality. What we might think of is the observability of the symptoms. So in someone with DID, the switching between parts was really quite apparent, and in DDNOS it's much less so. It's more subtle, I suppose. There's more of an influence behind the scenes than an actual apparent shift in behaviour. However, in other specified, you can still have these shifts in behaviour because it's simply that another category of dissociation has not been diagnosed, therefore you bring other specified in. which means that other specified can then be used to diagnose individual with DID where the shift is not so apparent, i.e. less severe. The impact on the individual or the observable nature of the dissociation is not so severe. Therefore, DID becomes OSDD when the shift in personality is subtle. And that subtle nature means that the difference in personality is not quite so readily evident. This is a really hard thing to measure, especially in an assessment where the individual may not be presenting with profound levels of dissociation for fear of demonstrating the nature of the personalities that be held within the system. As a way of trying to manage this, Dell started referring to complex dissociative disorders 1 and 2, where 1 is the more severe variant, DID, and 2 would be the less severe variant, Other Specified Dissociative Disorders. So we start thinking then in terms of the continuum or the spectrum of dissociation rather than separate diagnostic categories. And I think this is a lot more useful. And Dell, the way that he sets this stuff out, I think was extremely useful but wasn't picked up by the Diagnostic Statistical Manual when they were moving from versions 4 to 5, and I think that's actually a shame. And we know that this level of spectrum takes place when we bring amnesia into it. We know that in Europe, as I said, if there's a lot more amnesia present and switching, then we tend to think more of the DID thing. If there's less amnesia, we tend to think less of DID. But actually amnesia is present throughout different systems in very many different sort of shades. So the spectrum of amnesia varies enormously between individuals, both with DID and with other specified dissociative disorders. And given that because OSDD is such a broad spectrum diagnostic category, according to Dell, it is often the most frequent diagnostic category. So this is the biggest category of diagnoses that we have within the dissociative spectrum. Ellert and Nijenhuis put this really nicely. Ellert said, "A not otherwise specified category is not the place to put the prime member of a diagnostic family." So that's really making it clear that OSDD is the prime member of the diagnostic family. It's a very, very important diagnostic category, but I don't think we're doing the people with this justice in terms of framing the nature of their symptoms, because there's so much confusion. So some people have parts that do come out, some people have parts that don't. So does that make it DID or does that make it OSDD? And Ellert actually proposes a slightly different system by talking about minor DID and major DID, and this may be the way that we move forward, even taking into account the DSM categories. Minor DID then is marked dissociative symptoms. So EPs can be influential, can be occasionally dominant, can occasionally take over the body and present in the outside world with or without amnesia being present for the host after that period of dissociation. But the time is variable, so it's not so much a long period of time, and it has a less influential impact. With major DID we see much more observed dissociation. The switching between personalities is much more concrete, it's much more understandable in terms of consistent framework. Again, there may or may not be amnesia depending on the level of co-consciousness. So I wonder whether what we need to be thinking of is minor DID and major DID with or without amnesia. So this might be a way of describing an individual's personality system within the dissociative framework without pigeonholing a person into a category of other specified or not otherwise specified, which doesn't really describe anything. The whole point of other specified is that it doesn't really describe a single thing. It's just a broad, open catch-all that doesn't really understand the elements of dissociation within a particular individual. And what labeling someone with an other specified can mean is that it reduces the understanding, it reduces the sense of severity for that individual, because there may be elements at which they do lose time, elements at which personalities do come forward and take over. Within other specified we simply say, well, we call it that because it's not really DID. But it's a bit like DID, and actually what we might be best off doing is saying, well, it's minor DID versus major DID, which is really obvious, really apparent. The more subtle shifts of personality come down to minor DID, and then we add in with or without amnesia afterwards. So this references the work from Dell and Ellert and Nijenhuis, and actually it may allow us to introduce a more open and discussive form of diagnosis. If we're going to continue using diagnostic labels for people, why don't we make them more descriptive rather than formulaic? What this doesn't mean is that people can start re-diagnosing themselves or self-diagnosing themselves. This is never recommended. What we can start doing is opening the discussion within therapy to say that yes, I might have been diagnosed with OSDD, but I'd like to see it as being minor DID. It's a form of DID, but it's less severe. That opens the door to a lot more conversations about the nature of parts within the system and enables the therapist and the individual to start talking in the framework of DID using the guidelines for treatment for DID without actually worrying too much about the diagnostic categories. I hope this has been useful. I suppose it's a point to begin thinking about the way that we use labels and diagnosis in these categories of dissociation, which can shift and change over time. So I hope this has been useful. Please feel free to leave any comments, like and subscribe if you like the content on the channel. I'll keep providing more information, and do look after yourselves. So take care out there.